Welcome. I'm Michelle Kals, Director of Business Development with Rogers Behavioral Health, and I'm your moderator for today's webinar. Joining me today is Dr. Stephanie Eken, Regional Medical Director, who is based at Rogers Nashville location. We also have with us Dr. David Jacobi, Lead Psychologist for Rogers Child and Adolescent CBT Services, who is based in Rogers Oconomowoc campus. Before we get started, I wanted to give a quick overview of the format. The webinar is scheduled for 90 minutes. There is no need to check in. To receive CE credits, you must be logged into the webinar for the entire program. The PowerPoint slides and references will be available after the program via an email sent from CEGO. In addition, a recording of the webinar will be published on the resources section of our website within the next day or two for you to rewatch. Doctors Eken and Jacobi will give a 70 to 75-minute presentation. Following their presentation, I will facilitate the Q&A session. If you would like to ask our presenters a question during the presentation, please use the Q&A button, not the chat button, to send me a message. And I will try to get to as many questions as possible. At the bottom of your screen, you simply click on that Q&A button on the Zoom taskbar. I will review the questions submitted, then the presenters will address them during the Q&A portion of the webinar. Now I'll turn it over to our presenters.
All right, well, thank you very much, Michelle, and welcome everyone. In terms of disclosures, Dr. Eken and I really don't have anything to disclose, which is good. And to give you an idea of our learning objectives today, we really have two. One is to describe the three essential elements of exposure therapy, and then also to describe at least two strategies to reduce symptom maintaining behaviors. So Dr. Eken will discuss that later on. What we'll cover today will be kind of three different categories. Certainly essential elements, psychoeducation. So how do we go about doing that for patients and their families? Understanding some of the basic elements of exposure therapy. We'll also talk a little bit about therapist beliefs, more specifically sort of negative beliefs that therapists maintain that certainly can influence how they apply and utilize exposure-based interventions. We'll talk about compliance factors. So how does comorbidity enter into the picture? How do we have to, or how can we address some of those comorbid issues that occur? We'll talk about managing non-compliance. How can we help patients be successful, be committed to doing the treatment work? We'll talk a little bit also about functional assessment. So with kids, we know that there can be some issues in terms of getting them on board, getting them motivated. They may use different strategies as a way to avoid or to get something that they really want. Later on in the talk, Dr. Eken will address a symptom accommodation. So she'll talk about what it is. She'll talk about how that might interfere with our treatment of anxiety disorders. And then finally, how do we help families reduce those accommodations so we really can have the best outcomes we can? I wanted to start with a note about diversity. So our finding is that really both ethnic and racial minorities are underrepresented when we look at the research on anxiety disorders in adults and kids, as well as participation in treatment, specialized treatment that we offer for anxiety and related disorders. So Dr. Monica Williams and colleagues have done a fair amount of research in the area of particularly ethnic minorities, African Americans, and OCD and anxiety. And she says the following: although considerable strides have been made in understanding, diagnosing, and treating obsessive compulsive disorder, not all groups have benefited from these advances. OCD in ethnic and racial minority groups has been and continues to be a neglected area of study. The last 15 years of research has shed new light on OCD in African Americans with some fascinating findings and new questions to answer. And continuing on with the work that she's done, I wanted to point out some areas of interest in terms of understanding the lack of representation in research and certainly in terms of receiving appropriate treatment. We do know that generally in terms of prevalence that individuals, for example, African Americans, have really similar prevalence estimates as we see in the general population. We're also seeing that there are multiple barriers to treatment. So that may include cost in the form of having appropriate insurance, transportation issues to and from the clinic, stigma related to having an anxiety disorder, or even more specifically, OCD, and maybe not really understanding what OCD entails. A fear of therapy and fear of therapists, maybe not really trusting their motivations. There also may be a general lack of awareness of anxiety symptoms and certainly proven treatments for anxiety, something that we see across all groups, candidly. Lack of providers. So there are lots of places across the country where we don't see individuals, therapists who are really trained to provide that specialized treatment that we'll talk about today. We also know that other cultural groups may not believe in seeking mental health treatment outside of their group. It may be something that's preferred to be treated within the family system or within the culture. We also see misdiagnosis, that different cultures, African Americans may present and describe their symptoms in very specific ways, and this can be misinterpreted by therapists and other clinicians. So for example, those African Americans may describe their symptoms, especially their OCD symptoms, their unusual or unwanted thoughts, in a way that leads clinicians to believe that maybe they're psychotic. Obviously, if this is the case, they're not going to receive the care that they deserve. Also in terms of comorbidity, so especially in our programs where we see more severe complex cases, comorbidity is the norm. And so individuals with OCD and anxiety may present with other issues such as other anxiety disorders, depression, or even substance use issues. That can certainly complicate the diagnosis and treatment, but also for those clinicians who aren't familiar with the treatment or understanding of OCD, they may treat some of these other co-occurring disorders and really miss that primary condition for which that individual is seeking treatment for in the first place. We also find in terms of recruitment for research, again, lacking in that area as well. So we're trying to, and Dr. Williams talks about efforts to recruit for research by using less technical descriptors in terms of describing the research and what's desired. Trying to utilize more African-American therapists to conduct these evaluations, and doing more advertising in traditionally African-American institutions to really get those individuals interested and to buy into and participate into treatment. I wanted to present the next 3 slides, really cover some information, some research findings, some papers that you might be interested in on cross-cultural perspective. So I'd just like you to kind of take note. You will have access to the slides after the presentation today, so I would encourage you to take a look at some of these articles. We're also some information here and some resources on religious differences that we see. And then finally, regional differences. So there isn't as much research out there as we'd like, but we have compiled some of these resources for you if you're interested in taking a look at this. All right, well, let's move on and talk about essential elements. So we'll talk about psychoeducation for patients and families. We'll understand and try to explain some of the different elements of exposure therapy. And then we'll describe some therapists' beliefs and how that might influence in a negative way how we apply exposure-based interventions. So one of the things that both Dr. Eken and I do is provide training for our families whose children are in our programs. So we call it Parent University. And one of the things that we try to do is to provide them with really a good overview and information. And one of the things that we do is we talk about things like the difference between anxiety and fear and the advantages of anxiety and fear for children and for adults. Anxiety really is this apprehension about a future threat. So if I'm giving this presentation, I may be anxious about saying something incorrect or losing my place, and that will have consequences, for example, for you, and you may just decide to not be involved in this anymore. Individuals with OCD may have concerns that if they come in contact with a contaminant, that may lead to them getting sick or even dying. Individuals with worry have concerns about what will happen if my parents are away from home or I'm away from my parents. Could something terrible happen to them? Fear, in contrast, is really more of a response to an immediate threat. If I'm walking through the forest and I see a bear running at me, my body's going to do something to try to protect me. It's going to engage in what we call that fight or flight response. My heart rate will increase, my respiration will increase. Things that I don't need, like digestion, will slow or stop, all in the service of keeping me alive. So both anxiety and fear involve this increase in physiological arousal. And both, again, can be very adaptive. So that fight or flight response is designed to keep me alive, right? Do I defend myself or get the heck out of there? Anxiety itself can also increase what we call preparedness. When I'm somewhat nervous and anxious, I'm more focused, more ready to go, more ready to deal with that situation. We also see something called the Yerkes-Dodson curve, and that's illustrated here. If you noticed on the left, we have got performance on a given task, like a test, all the way from fairly poor to very good performance. On the bottom here, we see arousal, which is really synonymous with anxiety, and we have low levels to high levels. And what you'll see is that at very low levels and very high levels of anxiety, performance on a task like a test is not very good. If we're too laid back or we're not really concentrating and paying attention, we may not do well. Similarly, if we're so anxious that we can't concentrate, we can't retrieve information, we're also not going to do well. But there is this sort of optimal level, this area where some anxiety is actually very helpful for us. It keeps us focused, keeps us paying attention. We're able to retrieve information much more efficiently. So many of our families will say, well, I want my child to be on that comfort end of things the entire time. We want to disabuse them of that and say, no, sometimes anxiety is actually really helpful and it's a normal experience. And that is part of what we share with our families. Anxiety is normal. It's normal for me to be somewhat nervous giving this presentation. It's normal for a child to be anxious about starting their first day of school or, getting ready for a big test, meeting new kids. It's normal for them to experience some of that arousal. Anxiety is not dangerous. It certainly feels uncomfortable, and at high levels, it feels very uncomfortable. But generally, if we're able to kind of work through it, as we'll talk about with exposure, it won't last long and eventually it will decrease. We've already talked about the adaptive nature of anxiety, the fight or flight response, the Yerkes-Dodson curve. And what we really kind of suggest to our families that anxiety can become a problem when our bodies react to normal situations as if they were real dangers, right? So I'm doing this presentation, and even though my heart might be racing a bit, this is not a dangerous situation for me. Contamination, touching something that's contaminated, my body might respond, or I may think of that as being dangerous, but in reality, it really isn't. It's not really that dangerous, but I'm responding as if it is. So let's talk and switch gears and talk about different elements of exposure therapy. Some of you may be familiar with the cognitive behavioral model of anxiety, which really says that our emotional response, so anxiety, is connected to how we think and how we behave. Now, kids tend to describe anxiety perhaps in ways other than saying it's anxiety. They may say, my head hurts, my tummy hurts. They may act out or do other things. But generally, that feeling of anxiety is connected to thoughts. And when we think about anxiety and anxious thoughts, we think about thinking the worst, catastrophizing. If I don't wash these germs off my hands, I'm going to get sick and die. If I don't check and see where my parents are, I'm just sure that they got into a car accident. If I completely go blank when I'm giving this presentation, you're all going to just turn off your computers and walk away. There's also something called probability overestimation. It's assuming that kind of bad outcomes are really more likely than they really are. So someone who's had a panic attack may think, gosh, my chest feels kind of tight. Maybe I'm having a heart attack, or there's something wrong with my heart. From a behavioral perspective, what we tend to see with anxiety is a lot of avoidance. I avoid the things that make me feel anxious. So if I have contamination concerns, I avoid touching things that have germs on them. If I have social anxiety, I avoid contact with people, doing presentations, going to groups where I don't really know anybody. So it's normal to have that sort of reaction. But in trying to change that experience of anxiety, to reduce those anxiety emotions, we really can't do that directly. It would be fantastic if we could wake up in the morning and we maybe don't feel all that great and just snap our fingers and say, I'm going to feel happy today. It doesn't usually work that way. You usually have to do something to change the way we think, or to change the way or do something to change our behavior, or both. So with thoughts, we can look at what we call thought challenging. being able to look at those catastrophic and probability overestimation thoughts, looking at evidence for and against that, and coming up with what we would think of as a more balanced way of thinking, less catastrophic, more in line with the evidence. When we do that, we generally feel less anxious. Similarly, with behaviors, we try to reduce avoidance via exposure. And when we do that, we also see that there is an impact on our anxiety. It tends to reduce anxiety over time. We also know that behaviors and thoughts interact. If I change my ways of thinking, I'm probably also likely to change my behavior. And if I change my behavior, I'm also likely to see a change in the way that I think. So these things do interrelate. Exposure really focuses again on that behavioral piece of it. And this is sort of a typical scenario that we see. I'm going to talk about or use the example from the obsessive compulsive disorder world. We'll talk about how anxiety is maintained through negative reinforcement. If a child has a fear of contamination, so germs on things like doorknobs or shoes or floors or things like that, when they come in contact with one of those contaminants, their anxiety will predictably rise. They feel anxious, they're dreading that maybe this is going to make them sick or is going to harm them in some way. In response to that, they engage in a compulsion, which really generically, we call those things safety behaviors. Anything that's designed to reduce anxiety or prevent the experience of anxiety, like for example, avoidance. So once that child touches that contaminated object, their anxiety rises, they engage in that safety behavior or compulsion, typically of washing. Once I wash, my anxiety will predictably drop. I've gotten rid of those germs, they can't harm me anymore. The problem is that the hand washing becomes what we call negatively reinforced. I feel better. My anxiety goes away when I wash. Therefore, I'm more likely to do it again in the future when I feel anxious about germs. So at this point, the child is not really learning everything that they need to know. Then what is that? Well, what they need to know is this, is that if they were to come in contact via an exposure with that contaminated doorknob, and they refrain from engaging in that hand washing compulsion or that safety behavior, they would see that over time, their anxiety would come down with nothing but the passage of time. It's really kind of a neat thing to see. So in treating OCD, and to some extent also we'll talk about other anxiety disorders, that exposure piece is essential. And so what our therapists do here is they sit down with the child, they sit down with the parent, and they look at their assessment materials. They talk to the child, they talk to the parent, and the therapist is able to generate different types of exposures for the child to work on of varying levels of difficulty. Many of you may be familiar with a 0 to 10 or 0 to 100 scale. That's perfectly fine to use. And what we end up doing is we end up trying to pick exposures that are more moderate in terms of their difficulty. So for example, a child may be asked to touch a doorknob that's only touched by a few people, and they've rated that a 5 out of 10 on that 0 to 10 scale. What we would expect to see again is that anxiety would rise once they came in contact with that doorknob. What we want them to do again, instead of going to wash, is just wait. Keep your hand on that doorknob. And that process of what we call habituation occurs, where I go from anxious to less anxious with nothing but the passage of time. And that process of habituation is a good analogy is walking into a cool swimming pool. At first you feel really pretty cold, but after a while, you kind of get used to it, you tolerate it, you adjust to it, and the pool doesn't feel as cool anymore. The same sort of thing happens here. And when we do exposures, we try to pay attention to three things. One is we want to make sure that those exposures are repetitive. So we generally will have a child repeat the same exposure multiple times so that they get the experience of doing it over and over again and seeing that process, that habituation process occur. We also try to do exposures in a graded fashion, meaning we try to pick exposures that are moderate in terms of difficulty. Using that 0 to 10 scale, usually a 5 plus or minus is a great place to start. They need to experience some anxiety, but not so much that they're overwhelmed, but also not too little that they don't get the treatment effect. And kids and adults who do exposure need to experience some anxiety to benefit. We also look for something called prolonged exposure, meaning from that peak anxiety to the final anxiety, I need to let at least 50% reduction occur before I end that exposure. So in doing the exposure, as I mentioned, with touching the doorknob, my anxiety goes up to a 5 predictably, but then I need to hold on to that doorknob until my anxiety drops to at least a 2 before I would end that particular exposure trial. The beautiful thing about exposure and response prevention, and just exposure in general, is that as the child works on these exposure over and over again, of feeling anxious, letting that process of habituation occur, it gets easier and easier over time, to the point where the child can touch the doorknob and they're like, you know what, not a problem. I don't experience anxiety and I don't feel the urge to go wash anymore. So we are really making a fundamental change to that child's response to a once feared situation. So how does this work with other anxiety disorders? Again, we want to focus on doing the exposure piece, but also limiting or eliminating those safety behaviors that go along with this. So generalized anxiety disorder is the worry anxiety disorder, excessive uncontrolled worry about a variety of situations. Many kids who have worry about things that are remote. Something someday will happen to my family. Something terrible, some outcome will occur that I don't want to have happen. In those instances, we sometimes do what we call imaginal exposure, writing out a script describing those kind of feared outcomes and having the child reread that over and over again as part of their exposure work. We can also do other exposures. For example, kids have struggles in the classroom. They don't want to raise their hand. What if I say something stupid? What if people think I'm stupid? So we might have them do things like raise your hand in class when you're not completely confident. Individuals with GAD may also have struggles with making decisions. So an exposure may be for the child to choose the movie for the family to watch or a restaurant that they're going to go to. We may also have them cold call a friend that they haven't spoken to in a while. Take the chance that friend might be upset with you. And if they're avoiding doing things like academic work, practicing an instrument, we might, as an exposure, have them spend a certain amount of time engaged in those behaviors. Take the chance that maybe you have lost your touch or that you don't know the information. With separation anxiety, again, separating typically from a parent figure, we can just do some titration of that parent sort of out of the situation. Spend 5 minutes away, then 30 minutes, then 60 minutes, and then eventually doing so without telling the child when they're going to be able to return. And the child, again, adjusts and gets used to and habituates to having their parent absent. Now, panic and agoraphobia are a little bit different. Panic attacks initially come out of the blue. You get that fight or flight response activating when there really is no threat. And it's a very profound experience for people, and it's an unforgettable one. But one of the things that happens after having those panic attacks is that individuals come to fear the sensations that are associated with a panic attack. They notice if their chest feels tight. They feel some sense perhaps of dizziness in a sense, related to what they experienced when they had their panic attack. So one of the interventions that we do to get people to be comfortable with those sensations is what we call interoceptive exposure. We have them do things like hyperventilate on purpose for 60 seconds. We have them spin in a chair to simulate feeling dizzy, putting their head between their legs and standing up to simulate lightheadedness, doing stair steps to get their heart rate up. The idea here is that we want patients to not fear those sensations, because once they don't fear them, then they don't sort of work themselves into a panic attack. I don't like spinning myself, but I'm not afraid of it. And that's where we want to get to with these patients. We also know that individuals with panic disorder have a tendency to avoid situations where they fear they may have a panic attack. So we can do what's called in vivo or real life exposure. Gradually introducing them to going to the supermarket or the theater or being away from home by themselves. And we do that again in a gradual way so they get used to it, so they're not overwhelmed. With social anxiety, again, our focus here is on working on that fear of doing something embarrassing or humiliating. So we'll have kids call businesses and ask sort of odd questions. They can ask for time or directions from people. They may wear conspicuous clothing, something that's bright colored so that people have a tendency to look at them. They may engage and do presentations, prepared and unprepared. They may do things like drop a tray so that people will turn around and look at them, all in the service of doing that exposure, getting them comfortable with being around others and behaving in a social manner. Selective mutism is really thought of for us as a more severe form of social anxiety, where the child speaks either minimally or not at all with people who aren't their family. And in a very similar way, we work to increase things like the volume of their voice, of of eye contact with others. And again, we do it in a very gradual way so the child can challenge themselves, of course, but do it in a way that they're accepting of that and can benefit. So how do we explain exposure to kids? And sometimes we can do it in very simple terms. If you ask a child if they know someone who has a fear of dogs, or if they can imagine a friend of theirs having a fear of dogs, how would they help them get over that fear? Kids almost instinctively know how to do this, right? They'll suggest things like, oh, they would just need to spend some time with little dogs and then work up to large dogs, or be a few feet away from a dog, like my dog, and then get closer and closer and be able to finally pet the dog and realize that most dogs are really quite friendly and like to be touched. And then eventually, perhaps doing those things with a parent there, and then working toward doing and being around dogs without that safety person being present. Another way we can explain this is, getting on a big roller coaster. When you first think about it, when you see it and you're standing in line, a lot of people get nervous about it. But if you were to ride that roller coaster 100 times in a row, it would get probably to become very fun. In fact, it might even get to be a little boring after 100 times in a row. But we want kids to see that if they do these things over and over, they become easier. They won't be fearful of these situations or objects or whatever it may be once they keep practicing these things over and over. So we try to make modifications, obviously, in working with children. Children may not always be as understanding or insightful about their anxiety. They may also not be as motivated. And Dr. Eken will talk later about accommodation and how that can rob kids of that motivation to get well. One of the things that we can do is to try to externalize the anxiety disorder. So sometimes we'll use the phrases like the worry brain or bully or pest. I had one young girl who used the term Penelope to describe her OCD. It just worked for her. And it was a way for her to externalize that condition. We can also use metaphors that kids can relate to. So false alarm, like panic attacks or false alarm, or junk mail, thoughts that come into my head that really aren't useful or helpful. Spam mail, again, bully, false start in sports for things like that may be really relevant to the child and something that they can relate to. But even more importantly, we do things like, how has OCD or anxiety messed up your life? Does your OCD anxiety make you have to do certain things you don't want to? So again, trying to separate it out in a way to say, this thing, this OCD, this anxiety is influencing you in a way that's not very helpful for you. We can also do some what we call stigma prevalence exercises to reduce stigma. So for example, with obsessive compulsive disorder, we know that in an average size middle school, at least 4 kids will have the diagnosis of OCD. In an average size high school, it's being closer to 20. And we do know generally that anxiety disorders are the most common emotional behavioral disorders that we see in childhood and into adolescence. Other modifications we can make may include how we have kids rate their anxiety. So I've already mentioned that 0 to 10 scale or the 0 to 100 scale. And some kids, in fact, most kids will do just fine with that. They're able to rate things fairly accurately in a way that's helpful for them and for us. But some kids, very younger kids, or even kids who are struggling with autism, they really have a hard time grasping a number and what that means and what that translates to. So we can do things like developing a worry thermometer, right? The higher the temperature goes, the higher my anxiety. Faces, all the way from happy all the way up to pretty sad or worried. Colors, red, yellow, green. We use high, medium, low quite frequently, again, reducing the number of categories for the child. One of the things that I like to use as well are what's called tallies. So if I have a pretty good idea of how the child is doing in terms of their reactivity to anxiety, I may assign exposures for them to do, but give them some time guidelines. So I want you to touch that contaminated doorknob for 5 minutes. Then when you're done with that, the timer goes off, wait for 1 minute, and then repeat that again 4 more times. It's a way to get the child away from having to rate things. It gets them to doing things, which is what we really want them to do. And we're hopeful with whatever time requirement we give them, it'll be enough time for them to see that habituation process that I talked about earlier. We also want to have parents use that same scale so that they can discuss these things with us in terms of how the child's doing, as well as discussing these issues with their own child. So we can also, try to make this fun. I mean, think about for yourselves, if I were to ask you every day to spend 2 to 3 hours doing and confronting the thing that you fear the most, it really does take its toll. And it takes its toll, especially on younger kids who may not really understand what's happening. So one of the things that we can do is to try to make some of these exposures really more interesting, more fun for kids. So for example, something like OCD, finger painting with honey, bouncing a grape or something else off the floor and then eating it. And again, this is something that the therapist can do along with the patient. We can have them do what we call a touch list. So kids with contamination concerns and OCD, we ask them oftentimes to go around and touch things that they previously avoided as a way to really kind of bring home the fact that they're doing well. But we can do that in a scavenger hunt form. We can have kids with social anxiety do presentations on topics of real interest to them. We can, with kids with panic or high anxiety levels, we can have them do those interoceptive exposures I mentioned earlier. We can have them do stair steps with them or spin with them or do things like that, just to make it a little bit of a quote unquote competition and make it a little bit more enjoyable.
Yeah.
One of the other things that we try to do as well.
Jacobi, can I just say, like, this is like the one place that I feel like is, a common misconception that like there can't be a little fun added into the difficulty, but also it's like a place where kids and the therapist can really have a creative outlet that I think can be really engaging for the family as well as the therapist too, to have that creative outlet in a behavioral therapy modality. So some people don't always understand that you can be anxious and have fun, and creativity can all go together. So I think those were great examples of things that you did for exposures. And it looks like you're going to talk about maybe some things like from the behavioral standpoint too, to be really creative.
Yeah, and it's, the beautiful thing, and the thing that I really like about doing exposure therapy is you're only limited to your own creativity in terms of how to engage kids and do these sorts of things. It can get kind of routine at times, and a lot of your sessions that you'll do may be structured, and that's okay. They need to be structured in a certain way to really make the most use of the time that you have. But we really do want to encourage our clinicians to be as creative as they can, again, especially when you're working with younger kids, to really connect them to this and to motivate them to want to continue doing this kind of work, because it is difficult. Thank you, Dr. Eken. We also talk about reward systems. So we are big on praise. We are big on even token economy or just other rewards to show that child we get that they're working hard on this, that it's not easy. One of the things, token economy, that I use is what's called coins in the pocket. This is where you get a baseline for a particular behavior. So for the example here is, let's say, reassurance seeking. So I want reassurance from my parent or from staff about something that's designed to reduce my anxiety, reduce my uncertainty. Once we have that baseline, let's say the average is 50 times a day, we might provide that child with, say, 40 tokens. The tokens can be anything. You can be, again, very creative about the kinds of tokens that you can create. And whenever the child asks for reassurance, all the staff or parent has to do is hold out their hand and say token, and the child has to then reach in their pocket and give that token. Now, the parent knows what that means, so they don't have to provide reassurance. The child knows what that means, so there's no arguments. And the child is motivated to hold on to many of those tokens as they can, because typically then they can cash those in, whatever they have remaining, at the end of the day for things that they really want. And again, you can be as creative as you want with those tokens. We also want to be very specific about not only exposure guidelines, but that safety behavior or ritual prevention guidelines that I mentioned earlier. So we want to be able to quantify this. We want to know, is the child following these guidelines? We want to know, are they progressing? And so be able to quantify these things is very helpful. And to do that, you need to be very specific about what you're asking of that child. We also do and use something called a band book. The band book focuses specifically on those anxiety reducing safety behaviors that I mentioned. And essentially what we have the kid do throughout the day is to monitor things like requests for reassurance. And we have them mark in there whether they kind of gave in to that, what we would call a submit, or were they able to resist asking for reassurance when they wanted to. And that's what we would call a resist. And they would mark that in that band book. And what we see over time is that kids get better and better at being able to resist those safety behaviors. And then eventually the whole thing goes away because they've been working on exposures such that they don't need to engage in those safety behaviors after a while. One sort of caveat here as well is that response prevention or the safety behavior reduction is really a limiting factor. We need to assign exposures that the child can do without engaging in those safety behaviors. Sometimes that means we may need to pick exposures that are a little bit easier until the child can develop that confidence. Yes, I can touch that contaminated object and refrain from washing. Fantastic. That's really what we're looking for. All right, let's switch again. Let's talk about therapist beliefs. So even though we know that exposure-based interventions, and they've been around for many decades now, are very effective, exposure therapy, even in the 30 years I've been doing this, has not been as well adopted as I would like. Majority of clinicians who treat kids with anxiety aren't using exposure. They may be very cautious in how they deliver it, very concerned that they're going to overly distress their patient or that their patient will be upset with them. They may not utilize their session time effectively. So we encourage our clinicians in training to try to do some form of exposure if you can in every session, just to make sure that the child is doing it correctly, so that the parent can see how it's done, so that we can enter in and make adjustments if we need to in terms of how that exposure trial is being conducted. We also know that not having the proper education or training in how to utilize exposure-based interventions is problematic. So unfortunately, ERP is used only about 30% of the time to treat kids with OCD. Other clinicians may use talk therapy or thought challenging alone, and they really need to work on the exposure. That really gives us the biggest sort of bang for the buck, so to speak. It's really going to be the most effective intervention we can use for anxiety and OCD. So what do therapists believe about exposure therapy? Well, first of all, exposure therapy is unsafe, right? It maybe makes symptoms worse. And there's a little bit of truth to that, only that a lot of kids and even adults with anxiety and OCD will do their best to avoid. Parents, as Dr. Eken will talk about later, will accommodate in a way that the child doesn't necessarily experience all the kind of negative consequences of their anxiety disorder. So once we finally are able to talk to them and start our exposure work, they may find that that sort of stress to their system does all of a sudden seem like some of these other issues are coming to the fore. And they really aren't. They've been there. We're just stressing the system in such a way that these other issues are starting to emerge. There's also that concern that it can harm patients physically or emotionally. Again, we're trying to do this in a very graded fashion. We're not asking them to do the most difficult exposures. Anxiety itself, again, as we mentioned earlier, is not dangerous. It's not harmful. And it's not traumatic, right? Our patients are in control here. They are choosing or not choosing to do a particular exposure. We facilitate, we encourage and try to motivate, but ultimately they have the decision to do this or not. So we've not ever had any issues with this being in any way harmful in an emotional or physical way. Exposure therapy is intolerable, so patients perceive it as unacceptable. We've not had that experience. We do a really good job of explaining what exposure is, how we do it, that we're going to do it in a graded fashion, that this is what you can expect to occur if you do the work, as we've kind of laid it down. And so I think once you do that, patients are typically on board. This makes sense to them. They've probably used exposure in other areas of their life. And so this is really just an extension of that. There's also belief that arousal reduction techniques are necessary. What I mean by that is that when the patient is doing or the child is doing exposure and I see them distressed, I feel like I need to do something to eliminate that or reduce that anxiety, like engage in respiratory control, relaxation, or mindfulness. We really don't want clinicians to do that. We want to see that process that I talked about, that habituation process where anxiety levels go from high to low with nothing but the passage of time. That's what we really need. We don't want to interfere in that process. Lastly, exposure is unethical. It's inhumane, it's cruel to patients. Again, with good psychoeducation, explaining the benefits, looking to the research, patients are typically on board, both parents and kids. And I would say, candidly, it's inhumane and cruel to not use evidence-based treatments that you know are going to be helpful for the majority of kids and adults with anxiety. So just doing talk therapy is not going to do the trick. We really need to use these exposure-based interventions. The other concern, again, is that can lead to malpractice lawsuits. Again, the patient is in control here. We lay out for them how this is supposed to work, that they're going to experience anxiety. In fact, they need to experience anxiety. We're not going to ask them to do anything that we think would be harmful to them or anybody in their family. We're also not going to ask them to do anything that we ourselves, as clinicians, wouldn't be willing to do ourselves. So to me, that's really something that's not a real concern. So barrier to dissemination, so these negative beliefs can be a barrier. Again, as I mentioned, the underutilization of exposure. So again, there's a tendency, I think, for a lot of clinicians to default to things that they're comfortable with, right? Doing talk therapy, doing thought challenging, instead of having to deal with a child who's distressed doing an exposure. There can be an overly cautious delivery of exposure. So again, those efforts to minimize patient anxiety, just back away, do your relaxation because you look really anxious. We don't want that. We want that anxiety to come down on its own. Allowing what we call, again, the patient's safety behaviors, having them engage in a compulsion, having them avoid, having them distract, to do other things to artificially reduce their anxiety is also something we discourage. If anything, we want them to focus on their fear while doing an exposure, so they really then can see that their anxiety will come down no matter what. Reassuring patients of safety. I'm sure it'll be fine if you touch that doorknob. I'm sure those germs won't hurt you. Again, we want to discourage that. And then shortening the duration of exposure. As I mentioned earlier, we want these exposures to be repetitive. We do multiple at a given time. We want them to be gradual, and we want them to be prolonged, right? We want that at least 50% reduction in anxiety during the course of an exposure to see that process of habituation occur. Okay, so involving the family. Family-based approaches to treating OCD and anxiety have shown to have better outcomes. Having parents involved in the process is really, to me, essential. Of course, there's always going to be some exceptions to that, but for the most part, we want families involved in the process, especially with our younger kids. In fact, we think about parents and kids who are 12 and under as being co-therapists. We kind of train them to act as therapists when we're not there. We want to work with parents because we want to teach them how to do exposures really effectively, appropriately. We want them to identify and reduce their own accommodations that the family members are engaging in that is designed to reduce that child's distress. We want them to learn behavioral management skills, right? It can be very difficult. Many of our kids present not only with anxiety, but with other behavioral issues related to the anxiety, right? It's very difficult for them to adjust to that. And then lastly, it's really helpful if parents can identify new obsessions or compulsions, bring them to the session, and let's problem solve ways to come up with exposures for the child to work on. It allows us to catch mistakes early. We can role model managing difficult situations with the parent there. And it's something that we incorporate routinely in our programs. Our partial hospitalization programs, for example, require a parent to be there for the first 5 days, full days, to learn all of the things I just mentioned. And after that, we may need them there for the entire duration, or we may titrate them in and out as needed. Involving parents of adolescence. Parents, again, must be present for the assessment and certainly for at least the beginning or the end of session. We really want them to be aware of what the child's working on. We want to work with parents to establish a goals list, and they can even sign off on some of these things. Goals lists are really designed to motivate the child. They get points, they get rewards for doing their exposure work or getting up on time or things of that nature. They can also provide rewards, right? It's good for the parent to provide the rewards to acknowledge their child is working hard. We also involve and provide parent training in our outpatient and residential programs. We want to teach parents how to do this, how to be effective parents of a child with anxiety. For parents who nag or over-involved, we can use a kind of a fine system in a sense. We want parents to be involved, but not overly so, to the point where it's disruptive to the process. We also see a lot of parents who are just burned out, understandably. They've been dealing with this sometimes for months or years, and they've got a child who's got some behavioral issues related to anxiety. It can be really difficult. Try to be empathetic, try to understand, try to give them a break, essentially, as well. Sometimes parents need to kind of switch off in terms of providing that care. Always retain the right to discuss treatment with the parents. So there's that tendency, I know, when you're working, especially with teenagers, to want to keep things in confidence. But really important, I think, for that child to relay to the parent what are some concerns or symptoms of OCD or anxiety that are problematic. Let's talk about compliance factors. Comorbidity, especially in the programs where the child is seen as more severe symptoms, comorbidity is really the norm. The presence of other anxiety disorders is common. Attention deficit issues. We certainly see a fair number of kids on the autism spectrum. These kids can do just fine in treatment. We just need other ways to kind of help them be successful. Substance use, self-medication, especially in older teens. Marijuana, alcohol are very common ways to dampen down not only the physiology, but also obsessions or worries or things like that. Depression is also very common, typically as a secondary issue. The child's world shrinks because of their anxiety disorder. And so depression oftentimes results from that isolation and avoidance. Kids may explain or describe their depression in different ways. More, my head hurts, my tummy hurts. They may act out or be aggressive in response to those negative feelings. Learning disabilities also can be an issue. So if I have difficulty with processing and I have anxiety, this makes things like school that much more difficult. So we can work to reduce the anxiety, get them help, maybe an IEP for their learning disability that allows them to be as successful in the classroom setting. We also see eating disorders, certainly traditional ones like anorexia, bulimia, binge eating, but more commonly we see what we call disordered eating. Things like kids with vomit fear, changing their diet so they don't vomit, choking fears, or even certain kids with OCD may have very specific types of foods that they can eat or can't eat based on some superstitious or other kinds of fears. The beauty of working with kids and dealing with all these issues is that we get them back on that normal developmental trajectory and offset issues later in adulthood. This is really just kind of showing you, demonstrating to you about the comorbidity. This is fairly recent information from our child and adolescent residential OCD anxiety programs. And I just want to point to the comorbidity here, GAD and social anxiety present in both. ADHD and mood issues, again, also current. So, assess for that, be aware that these kind of disorders may co-occur with an anxiety disorder and may need attention. So things like depression may interfere with a child really being motivated or even able to benefit from exposure. Same thing with ADHD. If I can't concentrate and focus, it's very difficult for me then to benefit from treatment. Similarly, other anxiety disorders can just kind of make the presentation more complex, require more of our time and effort to disentangle and come up with specific exposures for those issues. Managing noncompliance, tantrums. Some kids show their fear by tantruming and crying. Some kids use it to avoid. We don't want to back off in those situations. We want to make sure the child is able to come back and re-engage and do exposure work. We can, though, if they're having a meltdown, just show that poker face, come back when the child is in a calmer state, and then can try to proceed as best you can with doing exposure work. Sometimes rewards don't entice kids. Sometimes we have kids who just don't seem to want to work for much. We can start treatment wherever we need to, in the parking lot. Some outpatient therapists are able to do home visits. We'll meet them where they are. We want to make sure parents are communicating the treatment isn't optional. The child has to engage in this. We tell the child they need to and deserve to be happy, have fun, do things like other kids. We assume that they're anxious, even though the presentation may not look anxious, right? The parent is aware, we are aware that they are anxious, even though they may not show it. Find out what their parents have told them or didn't tell them about treatment, right? Sometimes parents will make promises that really aren't in connection with what we're going to need to do in terms of getting that child well. Be matter of fact about the child hating therapy. Oftentimes they will communicate that, roll with that. That's just part of their frustration with this. Suggest how their cooperation might be advantageous to them. We want to act unconcerned, relabel any opposition as fear. We want to keep the session going forward, not get stuck. And then be patient, not only with the child, but with the adults, with the parents. This is new stuff for them. This isn't a complete change for them. So be patient as they begin to make those transitions. Most kids hate being bored and having to sit outside during a session, but if we need to just meet with the parents because the kids are unwilling, then we do that. We try to work with the parents to help them motivate their children. Tantrums need an interested audience to stay alive. So back away, maintain safety, but don't give the child an audience. Use lots of cognitive reframing with parents while the kids tantrums. And oftentimes it's helpful to have little prizes in your office that you can use as a way to reward the child for really the effort that they put into this. With teens, again, we want them to come to session short of them really being sick. So just having a tummy ache or headache doesn't allow them to be excused from school or from therapy. They need to come, and parents hopefully can support that. If a medical issue exists, we have a lot of kids these days with migraines. We want to work with a primary care provider to understand how this is supposed to be managed and what the expectations are. Most often the expectations are take your medications, do some other things, but then go to school, go to programming. Work with parents to get the teen to programming regardless of behavior avoidance. We oftentimes will have those calls with parents in the morning, my child is refusing to come. And so we continue to work with families, to work with the kids, to continue with that process of motivation. And again, the therapist needs to be able to talk freely with parents. Finally, the functional assessment piece. So when we see kids, for example, or a kid sees another child receiving attention, they may engage in certain behaviors, kicking or hitting or acting out, or the opposite, they'll look sad and down. And that may get attention from parents or from staff. And that may be exactly what the child wants. Another antecedent, the start of the treatment block, so our exposure block. The child again may look sad and down, isolate to themselves, or act out. And the consequence for them may be that they get out of doing treatment. And what we just want to be aware of here is how does that behavior function for the child? In many instances, it is designed for them to avoid having to do the exposure work. If we can kind of figure that out, looking at this functional assessment, we can then decide to do something different in response. The child looks sad, we say, oh, I'm sorry to see you're looking sad. You still have to do, 10 different exposures today. That's the expectation. Or if the child acts out, same thing. You're not getting out of treatment. We need to do it no matter what. So just as a way for you to remind you about the different functions of behavior, attention seeking, very common for our kids with anxiety, getting out of things. Again, looking for examples of that. And again, responding differently in response. Control, getting something that they need. And then self-regulation, which at times can be very healthy. If the child is overstimulated or lots of negative emotions, they can learn self-regulation skills, which may be helpful, but can also be maladaptive in certain situations, like kids on the autism spectrum who may need to do some self-stimulation or engage in those stereotypic behaviors. Okay, I will turn it over now to Dr. Eken.
Thanks, Dr. Jacobi. Well, thank you guys for taking part of your day to join us. I'm going to talk about accommodation, which is really one of my favorite things to discuss when it comes to anxiety and OCD in kids. So I'm going to give you some examples, and if you can go to the next slide, Dr. Jacobi, thanks. So really, accommodation are, anything that typically family members are doing to reduce anxiety, right? So it could be behaviors that they're doing to reduce ways that people might, that their loved one might engage in rituals or anxiety provoking situations. So here's some examples of some common accommodations that we see. So, assisting in someone washing their hands or completing a shower ritual, accompanying a team to the store due to panic. Teachers might not call in a classroom knowing that a child is socially anxious. Certainly parents provide reassurance for worries frequently in kiddos with anxiety. We commonly see parents changing their routine to be available to their children with anxiety, whether it's to answer texts or calls, or just to be able to go get them out of a situation. Buying items to complete rituals is very common. We hear them getting large, orders from Amazon or Costco to ensure they have the exact right soap or whatever that piece is that they need to complete a ritual. In our selectively mute children, we certainly see family members speaking for their child. And then even things like allowing a teen to confess to them if that's one of their rituals, repeating phrases or actions whenever they're getting scripted as part of a child's OCD, engaging in checking behaviors if the child doesn't do it on their own, so they may check closets or door locks or security systems or whatnot. And then allowing people to, their children to avoid, which is really common. So they might avoid sports activities or band or school or people. So maybe someone in the family is somehow anxiety provoking for a child. So maybe they don't go to family functions anymore, those kind of things. And so why do families accommodate? Well, to be honest, it's a lot easier in the beginning because it seems helpful and it works, right? Okay, so we now can go on and do this thing. If I just go get the hand soap that they have to use, I'm not going to have a big tantrum. They'll get their ritual done and we can move on. So it feels functional and like the right thing to do in the beginning. So they're doing it with the best of intentions. And frankly, accommodations for some kids work really well, right? If you have a kid who's anxious about going to school on their first day of school, which is normal, as Dr. Jacobi explained, you give them a little bit of reassurance. And for a kid without anxiety, an anxiety disorder, that works. And they go to school and they keep going. But it doesn't work for the kid who has an anxiety disorder because it's really just, I always call it, it's feeding the beast, that anxiety beast. Families also accommodate because what parent wants to see their child in distress, right? So if they can accommodate them and reduce that distress, then that feels a lot better as a parent. And sometimes parents can equate not accommodating to their child actually feeling unloved because their children will sometimes say, if you love me, you'll do this, or you don't love me because you didn't do this. But sometimes accommodation and love can get wrapped up in the family dynamic sometimes, and we really have to help them unravel that and see that love is not not part of that accommodation. And then for some families, they fear their child's behavioral response. It can be a tantrum, it can be threatening to harm themselves, whatever it is that is scary and can be unsafe for their child. So how often does accommodation occur? There's lots of studies out there. I say they're all wrong because they say anywhere from 60 to 97%. And I say they're all wrong because we accommodate 100% of the time because we do even in treatment, right? You're not gonna take away everything that's been happening for a kiddo who's been struggling, who's been avoiding, or that you've been engaging in their behaviors. I just have yet to meet a family who had to not engage in some level of accommodation, particularly because they didn't even understand sometimes that they were engaging in accommodation. So siblings also, this is not just a parental piece, this is other family members, siblings can sometimes, particularly young ones, can sometimes be enlisted in rituals. The most common types of accommodation that we see are reassurance is number one, and then waiting for rituals to be completed. We often see families holding up things because of that, assisting with avoidance because of anxiety, and then directly participating in rituals. And so why do we care about accommodation? Why is it a big deal? Well, it's a big deal for a lot of reasons. Number one, our treatment outcomes absolutely are worse if we don't address accommodation. But for the family, for them, it leads to overall negative family dynamics. often there's an imbalance in parents of who's willing to accommodate and who's not. You might have one who's really going to accommodate a lot of behaviors and someone else who may not do any. So that can be very difficult in families. But most of all, it negatively reinforces the behaviors of the person with anxiety or OCD, because you're allowing them to always avoid the anxiety or other negative consequences that may be a result of them, engaging in this. So accommodation is really important to very clearly address whenever you're doing treatment. The other thing is, I think it really tells kids that they're not able to handle anxiety, right? Because you don't allow them to do the exposures maybe in the best way, and it prevents their habituation. And habituation is it's really the name of the game for these kiddos to be able to make the progress that we need. It also, as Dr. Jacobi alluded to earlier, it can reduce their motivation, right? So if there's a lot of accommodation, then some kids may not feel motivated. We literally have had families in extreme examples, where something's been contaminated, where they've put their child up in a hotel or another home, and they don't have to go to school and they have no responsibility. And then they are allowed to do other activities that are more, enjoyable to them. So it can really get to some extreme versions. The impact on the family of accommodation is significant. So definitely linked to more family dysfunction and stress, because it can take up a lot of time for particular family members. Often there is a family member, one of the parents, that sort of gets drawn into it more and becomes the person that's more responsible for the accommodation, and then is more absent for the rest of the family. And then it changes the routines of the family. So maybe the dad or the mom is not available to the other children or to their spouse. So it absolutely impacts marriages or partnerships as well, because there can be conflict over how accommodation does or does not happen. And it just takes up time, which reduces our availability to, each other in general. The other piece I really like to always talk about is the siblings, because sometimes they don't understand what's happening, and they are participating in accommodation as well. And they are seeing their sibling worsening and their parents taking up all this time, and their mental health outcomes are absolutely impacted by what's going on in that family. So I think it's important to address. Additionally, accommodation just for different family members can also reduce their ability to engage in their own self-care. And we all need that, as we all know, in 2020. Parental factors that can lead to increased accommodation are, as you can imagine, parental anxiety or OCD. So, we know there are some genetic predispositions already in some of these mental health disorders. So if you have parental anxiety, you can imagine the over-identification that can happen with their own child's anxiety. So then it may give them an even reduced ability to tolerate that child's distress, because they know very intimately how it feels to feel stressed and distressed by that anxiety. About 20% of parents of kiddos with OCD have OCD themselves. So it's very interesting. Sometimes it can be in the same domains. Sometimes it can be very different, but it's not uncommon for them to engage in each other's rituals. And once again, there can be that over-identification of really knowing how much engaging in rituals can reduce that distressed feeling. So the other piece is just that over involvement of parenting that's developmentally inappropriate. Obviously, for a 6-year-old, you need a parent who's really involved, but for a 16-year-old, that's going to be different. And so if there's this history of developmentally inappropriate involvement in parenting, then there's probably been a lot of rescuing from situations and consequences, and it's a pattern that's going to continue whenever there's anxiety involved as well. The problem, I've mentioned some of the problems with accommodating, but there's just ongoing ones. A big piece is it conflicts with our CBT goals. So that's also why you've got to address it in sessions. You're limiting opportunities for kids to learn about fear, the feared consequence that they have doesn't happen. It's reducing that motivation for change, and it's preventing habituation associated with poor treatment outcomes, as I've already mentioned. So there's a study by Tara Paris and her group in 2012. There's others as well, but this is just a nice summary of hers, that family accommodation is a major predictor of treatment response and relapse in children and adults with anxiety and OCD. So even though we're talking about kids, if you treat adults, it's important to address family accommodation with them as well. And family conflict and blame typically increases with accommodation, which also increases, also worsens outcomes. And then for the long term, in adulthood, the more levels of accommodation there are, actually the worse your outcomes are. So I talk to this with parents, as Dr. Jacobi mentioned too, the great thing about working with kids is the earlier we treat it, the better their trajectory is going to be, and they can get back to where they need to be developmentally. But also we can talk about, like, for the long term, their outcomes are going to be better if we reduce that accommodation. And then family cohesion is also an important piece of better treatment outcomes. So families that can be cohesive and work cooperatively together can have better outcomes. So here's some strategies to just discuss with parents becoming a parent coach. We think it's critically important that parents are parent coaches with you. I always talk about sort of mentally preparing yourself that your child will not thank you for taking away accommodations, because it's going to make them more anxious. So it's likely that they will actually get a little bit worse when you take away some of those accommodations, which is part of that extinction burst in behavior that we see, as well as, just changes within how they're having to deal with their anxiety, which Dr. Jacobi mentioned earlier. I think it's really important to be aware of your own tone of voice and body language. And we talk with parents about this a lot. As a therapist, I think modeling, like, just, calm and kind of having that, calm demeanor and poker face. Dr. Jacobi's brilliant at it, I think, with our families, and helping them know that we can get through that, and helping them feel confident as well. And then also, I'll talk about this explicitly, but being empathetic without being accommodating. You can absolutely validate your kids and their anxiety and not accommodate them. So when we're reducing exposures, number one, it's got to be in concert with the treatment goals. So the child or teen needs to know that you're going to work on this. It shouldn't be done secretly. Often they're better reporters than their parents are of what accommodations are being provided. And so you can actually make that part of their exposure hierarchy. And, in certain settings like residential, it gets withdrawn more quickly, but you can withdraw it gradually in an outpatient setting, just like you would have them do exposure. And so you want to talk to them about that and say, we're going to work on this together. And that by, pulling away accommodation, we're actually, starting to starve that OCD monster and overcoming them. You also need to have a plan if the child becomes upset or overwhelmed. Dr. Jacobi mentioned a lot about, tantrums. I often see the common mistake about parents wanting to really engage in a lot of conversation when their kids are becoming escalated and upset. And if you think about yourself when you're anxious or upset, that's probably not the best time to talk with you, and it's usually not the best time to talk with the kids. So we really talk about timely disengagement. And not over talking whenever the kids are in potential meltdown mode. And then also having consequences. I almost feel like we have to give parents permission again to provide appropriate consequences to children when their behaviors are inappropriate. So just because they have anxiety doesn't mean that there can't be, consequences in the household if they've displayed, inappropriate or unsafe behaviors. And then going back and processing instances of difficulty when maybe you were withdrawing accommodation and it didn't go so well, when your child is calm, and hear from them also maybe why they struggled with it so much. But you need a little bit of time, not too much time, but a little time for when they're calm. For reassurance seeking, I think parents, you really have to talk with them about it because they don't see the reassurance that they're providing often. Once again, the children and teens are better reporters most often about when people are giving them reassurance, even when we do it, because we do it as therapists as well. So examples are you sure you locked the doors? Did you touch my sheets? Did I hurt your feelings? So that, kind of checking in frequently. Do you love me? Can be a reassurance seeking question, which is super hard for parents, right? Because who wants to answer with anything but, of course I do. I love you so much. I mean, but that can be a place where we do an exposure where they actually can't give them an answer, because we want love to be about love, right? We don't want love to be about anxiety. And that's where we have to help the parents see that sometimes that question is actually about OCD or anxiety. Even making the statement, I did a bad job. I tell you what, when a 6-year-old says that to me, I want to come in and say oh my gosh, you did so great. What are you talking about? But that can be that little throw out for hey, I'm trying to get that reassurance. And even calling parents from school just to make sure they're okay. How are they doing? That can be a reassurance as well. So I'm not going to go through all of this because I think we're probably having limited time now, but I love this form. The St. Louis Behavioral Health Group came up with this. I want to give them all the credit, but it's a great way to look at information seeking versus reassurance seeking with children and teens. And so just some big things to point out is, if you're reassurance seeking, you're often asking people who are unqualified to answer a question, and you're seeking a very desired answer that's absolute and definitive. And we know there are many questions in this world that have uncertain answers, and they cannot tolerate that well. So strategies that we share with parents about reducing reassurance, things like putting it back to the child if they ask a question and say, hey, what do you think? Or you hear us say a lot, I mean, maybe yes, maybe no, or I don't know. We'll leave it uncertain with them. Assigning how many worry questions they get per hour can be really effective too if they do a lot of reassurance seeking, to start to hone that down to a smaller amount. I really like delay in reassurance seeking with some of our middle school kids, where you can have a predetermined length of time before you would answer any questions that you think are reassurance seeking, to increase their tolerance for uncertainty. And just to play off that, the long-term versus short-term gain, I love that with adolescents, because they can really think through that of, what if I answer this question now? Yeah, I mean, I'm making your anxiety better, but what's the long-term gain if we don't answer this right now, and help them work through that. Coins in the pocket, you can use that as well for reassurance. Like Dr. Jacobi mentioned, they can give up the coins. And then you can also, I like to role play responses with parents when we're working on this. This part is really important, the reassurance versus validation, because again, they are not the same thing. So again, reassurance is that act of removing doubt or fear and reducing someone's, doubt, fear, or distress, and to offer that certainty. That is not the same as validation, which is that verbal or non-verbal communication to another person that his or her emotions, thoughts, and behaviors have causes and are understandable given the situation or individual's learning history. And it's non-judgmental. So you can, I think it's in maybe the next slide where we maybe give some examples. Yeah, I mean, you can absolutely say I want to make sure I understand, you're feeling anxious and worried because you have a test coming up. Is that right? Or, not having certainty about something can be really scary. So I love this table too about showing some validating responses. And then here's the last thing that we have, which is a case study that just can highlight some ways that accommodation might be happening. So Robert's an 11-year-old with severe contamination fears of germs in toilet water. He avoids going into public restrooms, touching doorknobs, and shaking people's hands. He has hand washing and cleaning rituals that take him over 8 hours per day to reduce his fear that he will die if he's not clean enough. He does not allow his family to touch him or sit in his 2 designated spots at home. There's a special place in the laundry room where his clothes and school items are placed away from everything else. Robert will become verbally and sometimes physically aggressive if his younger sister, who's really gross, enters his room or touches his items. Now, normally if we weren't virtual, I'd ask you guys to like come back and tell me like what are some of the accommodations you'll see, but I'm gonna have Dr. Jacobi participate with me, and maybe we can rattle off some of the accommodations that might be really apparent and maybe some that are implied in here. So, you know, I'm imagining he's hand washing and cleaning rituals that are taking 8 hours per day. I'm imagining that somebody is supplying the money and actual like soap and whatnot, because he's 11. I imagine he doesn't have the money to do all that.
Yeah, you know, he's spending 8 hours a day as well, engaged in his rituals. So I'm wondering, is he going to school or doing his schoolwork, socializing, things of that nature?
Yep.
He also has a special place in the laundry room for his clothes. So again, the parents are providing that for him.
Yes. And you wonder if he washes his own clothes too. I imagine that he probably does not, because it's contaminated, or at least he doesn't put them in the washer.
Yeah, and also, are parents tolerating him being physically aggressive with his younger sister? What is the value in the household, and is there a natural consequence if he does, you know, act violently toward her, or just he is verbally abusive with her?
Yeah. And like she's having to participate in the accommodation too by like not entering his room or touching his items. And you know, we don't know exactly how old she is, but that may be really, you know, difficult for her to always remember to not touch all of his items as well.
I'd say the other thing is how far, you know, what can the family do? Can they go to the store because he needs to have his special, you know, bathroom? Can they go on vacations? How has this impacted the family more generally?
Yeah, absolutely. Or does he get to use the parents' bathroom because he shares the bathroom with his sister normally, and now they can't do that, and now the rest of the family has to use a single bathroom, things like that. Yeah, so there can be lots to untangle in a case like this. And so lots of questions that have to be asked to family members whenever you're looking for accommodation. So I think this is the last part where we can now go to questions. And I think maybe Michelle's going to help us with some of the questions that are out there.
Yes, thank you so much, Doctors Jacobi and Eken. Wonderful presentation, and we have so many questions. I don't think we'll get to all of them, but one that I'm seeing a common thread that a lot of our participants would like to know is practicing contamination exposures during a pandemic and how you work around that.
Yeah, I mean, I can try to answer that. And that's come up for us, right? I mean, that's a question our clinicians are asking as well. And I think what we're trying to do is to aim toward functionality. You know, we want people to follow the CDC guidelines within reason, right? I mean, it's a difference between, you know, washing your hands once and washing your hands multiple times. It's wearing one mask or wearing multiple masks, you know, when you go out to, you know, public spaces and things like that. So I think our goal is to identify people who are worried to excess about these issues, either part of a generalized anxiety or OCD, and then try to get them to alter those behaviors to a more functional state, to follow those guidelines. And I think once they do that, that takes the attention away from the fear, right? I'm just doing what everybody else is doing. I'm not overdoing it, which hopefully will lend itself to decreasing their worry or any obsessions they have related to that.
Yeah. So I just add that, you know, we're not swinging the pendulum quite over as much as we were before, when we're in the midst of a pandemic, where we would really, you know, say you can't wash your hands today. Now we're following, you know, the CDC guideline when we're in the midst of a pandemic. And Michelle, maybe you can help answer this question, but I know we've had some webinars on specifically OCD in the COVID pandemic. And so I think those are on our, maybe, are those available on our website that people could go to?
Yes, they're on the Rogers website under resources and then webinars.
Yeah.
This recording will be on there as well, but we have quite a few with Dr. Marty Franklin.
Yeah, and he's done full talks on this if you really want to dig into that more, and they've been excellent.
Thank you. Another question that seems a common thread is, do you find children on the autism spectrum habituate more slowly than children who are neurotypical?
I definitely, Dr. Jacobi, feel free to chime in, but I'm happy to start off with that one. I think we can definitely see that happening. There are some, some shifts sometimes we make in treatment for kids with ASD and OCD around rating their anxiety, sometimes the repetition of how they do exposure, sometimes assigning like time frames that they complete their exposures in. And so sometimes it can take longer for them to habituate. But also, I just want to point out that sometimes we have seen people assign exposures around what are more core ASD symptoms, but they've been classified as obsessions. So, like for instance, we recently had a patient that we treated that had ASD and they really did have OCD. But one of the things is they were labeled as being obsessed with trains. And that was actually part of their ASD. That was one of their interests, one of their focus interests. And so they're not going to habituate around like core ASD symptoms. It really has to be an obsession.
Yeah, and that's all great. I would add too, just the idea of being very concrete. So we're really not going to be doing much in the way of thought challenging. It's going to be very exposure based. As Dr. Eken said, the repetition, really, really important. So having them do the exposures over and over and over again, it may take them longer to benefit than a kid who doesn't have ASD. And then the generalization piece. We need to be active about doing exposures in a variety of different contexts, because we may find that a child is able to do an exposure in the office, but literally they can doing the same exposure outside of the office produces a lot more anxiety. So we have to work to do the work in a variety of different contexts for them to benefit long-term.
Yeah, because we can actually become part of their safety behavior if they're always used to doing exposure with us, right? It's so critical to do it in other environments.
Thank you. A lot of questions around the actual exposure and the interaction with the clinician and their response. Can you speak more to what you would do or say to a child during exposures? Do you just focus on their anxiety, say nothing at all? I'm confessing that I'm one of those that have erred on the side of encouraging them to take a deep breath, etc., during anxiety-provoking situations, or you will feel better soon. But those are just distraction reassurance. And I'm reading this in the form of someone's question.
I can handle that. We basically saying nothing is probably one of the best options. So just allow the child to do the exposure and be silent. Let them kind of go through that process. It's awkward, right? I mean, you're kind of waiting for that process to occur. We're waiting them to see that 50% reduction in their anxiety while they're doing the exposure before they're done with that. The other thing we can do is to ask some questions about the fear, to really hone their thoughts and their attention to what is it they're afraid is going to happen by them, for example, touching a contaminated doorknob. And they may say things like, I'm going to get sick and I'm going to pass along the germs to my family and they're going to get sick and people are going to die. And to me, it would be one of the other ways through that. Focus them on the fear or just be silent, let them work through that process on their own.
Yes, I would say, just to add to that, I mean, we want to avoid providing them with reassurance or engaging in any kind of like coping strategy to reduce anxiety during that time. Because, Dr. Jacobi said it, but I like to repeat it. The most powerful thing that they can walk away knowing is, like, with the sheer passage of time, anxiety will come down, and it becomes quicker that it will come down if they can habituate in these exposures. And that's really amazing.
The difficult thing with doing exposures, and we draw the parallel with our parents as well, is that it's tough seeing somebody that you're helping be in distress. And sometimes they get mad at you as the therapist, right, for encouraging them to do these things. And it takes a while to get used to that, to get comfortable with seeing a patient in distress. And our parents do the same sort of thing. It's difficult for them to see their child in distress, which is why Dr. Eken talked about accommodation, why it's such a natural response to want to rescue your child, reduce their distress, improve their functionality. But even parents, to be successful, need to get comfortable with the idea and with seeing their child in distress, because they are finally confronting their fear. Kids are anxious anyway. We're finally using that anxiety of the exposure to help them get well. So it's actually a really productive use of their anxiety.
Thank you so much. Another question was, what if I don't feel comfortable with myself with an exposure due to an anxiety or fear, such as a spider phobia?
I'm happy to field that one. So I always say we can't ask a patient to do an exposure that we're not prepared to do. So it's a natural human condition to have some anxiety about some things. Sometimes for a lot of us, it doesn't get in the way of our functioning, which is great. And so I'll confess, like when I first started doing ERP, I am not particularly fond of spiders. In fact, if you spoke with my husband, he would tell you that like I avoided a lot of situations like killing spiders, and I would call him, elicit his help. Although I went to the University of Richmond, which is the spiders, but I truly considered not going there because of their mascot. So I would say you have to start doing some of your own exposure work to get prepared to do that with patients, because you're going to run across a patient who has something that doesn't, get you real excited and might make you anxious. And so we do that with our own therapists at Rogers, right? If they have some worry, we got to start working through it. So I have looked at videos of spiders. So I can say proudly last year that I had a tarantula molt thrown at me, and I didn't love it, but I did okay with it, and I can deal with spiders now. So it's possible and helpful for ourselves to actually manage some of our own anxiety, right? That's the beauty of CBT with ERP, is it's helpful for ourselves as well in those kind of things.
Good.
Fascinating. One more question before we wrap up that seems to have a common thread. And if your question didn't get answered, you can send me an email after if it didn't get answered during or after. What role do mindfulness techniques, breathing, etc., play in exposure therapy?
Well, I'll take a first stab at it. I think as Dr. Eken already mentioned, we don't encourage therapists to, encourage patients to use that during the process of exposure. Where I would see that can be helpful is outside of the time that we're working on exposures explicitly. So some of our patients, particularly with OCD and worry, may walk around at a heightened level of arousal. They're just anxious, on that 1 to 10 scale. They may be walking around always at a 2 or a 3. So they can practice doing mindfulness, breathing retraining, or relaxation skills as a way to kind of reset that physiology, to drop it down a little bit so they're a little bit more comfortable. But again, not to use that during any form of exposure.
Can I just throw one thing in there? I know our time is almost up, but I see a real imbalance when patients make it to us that mindfulness and breathing and all those things can be helpful, but typically that's almost all that patients have done, and they've not gotten to exposure, and exposure is where it's at. So the coping strategy, you can talk about it, and they need some of that, but the vast majority of your time with the patient should be spent doing exposure. It is how they will get better. And I often see the exact opposite in patients that get to us. So yes, do those things, but exposure is where it's at.
Absolutely fascinating. Thank you again, Drs. Eken and Jacobi, for taking the time away from your clinical practice to share your valuable insights with us. Helping a patient on the road to recovery means collaboration among everyone involved in their treatment. And with locations across the country, our treatment teams are ready to partner with you. Rogers outreach representatives are happy to answer questions regarding our treatment services, as well as learn more about your practice. Before we conclude, I'd like to ask our presenters to share any specific recommendations on additional resources for our participants.
Yeah, I mean, the ones that are identified here are many of our go-to: Anxiety and Depression Association of America. One that's probably not on here is the International OCD Foundation, or IOCDF.org is a really great site. Another one that I recommend, believe it or not, it's called anxietycanada.com, I believe. And I've been very focused on anxiety disorders, some information for adolescents as well as parents on how to manage and navigate this.
I agree with those. Those are great resources.
Thank you again, Drs. Jacobi and Eken, and that about wraps it up, everyone. I want to remind our participants that those of you who met the required time commitment will be eligible for CE credits. About 30 minutes after the webinar ends, you'll receive an email with a link to the mandatory evaluation form. Once you complete it, you may download your CE certificate for the event. You will also be able to access PDFs of the PowerPoint presentation slides handout and a complete list of references. On behalf of everyone at Rogers, we look forward to partnering with you to help support your patients. Thank you.